Hello and very good afternoon to one and all. I shall be presenting more than a Staghorn, our interesting case presentation. I am Chetanya. Thank you for allowing me to present it remotely. So we had an 18-year-old male, Lakshmanan, from Vanyambadi, studying at Islamia College, who presented to us with 5 days of fever, 4 days of cough with expectoration, 3 days of facial puffiness and edema, and 3 days of decreased urine output. While, of course, we took the history and examination, I would at the outset like to show everyone the radiograph for the patient that was taken in the emergency. This is the USG KUB of the patient, and as is clearly seen, left side, a Staghorn calculus is appreciated, and on the right side, in the distal ureter, we can appreciate a distal ureteric calculi. So these were the findings on presentation for the patient on the plain radiograph, and we proceeded with a ultrasound KUB, which showed on the left kidney a 1.5 centimeter Staghorn calculi, and right-sided HUN was visualized with the distal ureteric calculi of 1.3 centimeter, and bilateral kidney size was 11.8 and 12.1 centimeter. So, on further speaking to the patient, there was a significant past history that the patient had. At the age of 3 years, there was history of passage of stones in the urine, and the patient was evaluated at that point of time with the urine oxalate level that was found to be elevated 112. We shall have a discussion on the levels later, and the patient was started on pyridoxine at that point of time, but a genetic diagnosis was not obtained. uh, the same problems continued to recur. Next year in 2011, the patient had a vesical calculus and a bulbar urethral calculus, which underwent extraction, at which point of time the creatinine level was found to be zero point 0.6. Then in 2014, at the age of 7 years, oxalosis was suspected for the patient. CT, KUB, and ophthalmological examination at that point was normal, and he was on tablet pyridoxine, which was continuing, and his serum oxalate levels were done at that point. So that was 9.4. Likely at this point, if serum oxalate was done, some renal dysfunction would have set in, as we'll discuss in the following slides. And the 24-hour urine oxalate done at this time had a value of 84. And after this point, the patient was lost to follow up. And after 2017, there are no records. So after 8 years, he presented to us in JIPMER at the age of 18 years. And that is the past history of the patient. Family history, the parents had a non-consanguineous marriage. Um, the father is 52-year-old and the mother was 44-year-old. And there was a significant history of twin sibling death at 8.5 years of age. So this history was not obtained initially, as the parents were hesitant to reveal this history. But later, an aunt came who told about the sibling, which was further corroborated by the parents. And there was a history of renal stone disease, which underwent surgical intervention in the brother, and he also had one session of hemodialysis. But the brother had expired at 8.5 years of age. On examination, the patient had facial puffiness, bilateral pedal edema, BMI was 19, likely having some undernourishment, and the CVS was having a loud S2 with the P2 component being loud, and bilateral basal crepitations were there in the respiratory system examination with bilateral renal angle tenderness. CNS examination, patient was well conscious oriented, but there was distal neuropathy in the bilateral lower limbs, and proprioception was preserved. In the initial labs, we had anemia, normocytic, hemoglobin of 6.8, MCV of 84. Counts were normal. Platelet counts were also relatively fine. No pancytopenia picture on presentation. And a urea creatinine was extremely elevated, urea of 200 and a creatinine of 23, with reduced urine output of around only 100 ml. That also blood tinged. The ABG was having severe acidosis, pH of 7.16, with a bicarbonate of 11. So severe metabolic acidosis on presentation with an initial procalcitonin of 170. Ferritin was 439, PTH was 204, likely suggesting progression to chronic kidney disease and end-stage renal disease. The initial blood and urine cultures were sterile. We did the urine cultures because there was bilateral renal angle tenderness. So we wanted to rule out any organism in the urine. And the URME did not have any crystals or any active sediment. And the pH of the urine was found to be 6.5. So we had taken after dialysis. So the patient was immediately taken up for hemodialysis. 2 hour session was given, and following that, we also took a CT of the thorax and the abdomen. So we can have a look at the plain CT of the thorax, the lung window, which shows bilateral infiltrates along. So two types of infiltrates are seen in this, and air bronchogram sign is there. So likely we suspected some over pulmonary edema was there, definitely bilateral, and but despite dialysis, the infiltrates persisted and alveolar opacities were there with air bronchogram. So we suspected consolidation. and the patient was started on antibiotics, with the source being likely lung. And here we can have a look at the CT of the abdomen. The abdomen window's soft tissue is highlighted here. And as we can see, first we'll visualize the left kidney, showing to us the Staghorn calculus that is present here and seen here, well appreciated. Along with that, in the right kidney, we are able to make out nephrocalcinosis, which is very prominent here, particularly in the pyramids. We are able to make out nephrocalcinosis. And as we go lower down, as you remember in the radiograph, we had a right distal ureteric calculi, which will come into vision as the image descends further down. Apart from that, in the bone window, we could not appreciate any significant bone involvement, as we shall see going forward. That bone marrow is a late site for oxalate deposition. So this is the right-sided distal ureteric calculus that comes into vision for the patient. And as it goes further, that's the plain CT, non-contrast enhanced CT of the abdomen. So no vesical calculus or no urethral calculus is visualized. So the patient was managed with hemodialysis. In fact, for the pulmonary edema that the patient had, the patient required intubation support and was managed in EMS HDO initially. Underwent one peri-intubation cardiac arrest also, but received spontaneous circulation within one cycle and required a same-day sled session, a 6-hour long session for sled, after which there was significant improvement and was given transfusion support with 3 packed cells. And the patient improved with the above therapy. Likely, the worsening was due to some pulmonary infection. We did not have an organism, but the patient improved with 7 days of antibiotics. Piperacillin was given. So the patient had was managed initially in EMS HDU, and he received hemodialysis and SLED on the same day. So we had given antibiotics. Initially, piptaz and vancomycin was started. After cultures were sterile, vancomycin was stopped, and hydrocort also was stopped initially. Then peptaz was continued. And within in the EMS HDU itself, we achieved a significant tapering of the FiO2. And from the initial ABG, that was pre-intubation, we had a pH of 6.96. There was a significant improvement after SLED to a pH of 7.41. So the patient was shifted to medicine ICU after that, and the patient was extubated within 2 days. The AT aspirate was sterile. Bilateral degestenting was done. So although initially in these patients, upfront management with PCNL is recommended, but that was deferred in this case by the urology team as there was presence of infection. So they wanted the infection to resolve, and since urea creatinine was persistently elevated, they wanted some dialysis before they went ahead with definitive stone clearance. This is planned next week. And post degestenting, patient had a urine output of 500 ml, so there was definitely oliguria. And the patients were shifted to ward. Antibiotics were continued. Repeat procalcitonin was 23. Further 2 sessions of hemodialysis with some ultrafiltrate removal were continued. At this point of time, we sent a genetic testing. So one question we had at this point in our management was whether a genetic testing will help now that the patient has already gone into chronic kidney disease with end-stage renal disease. And we are thankful to Deepak sir for guiding us on this and facilitating us to send this genetic testing at no cost to the patient. So the idea behind sending genetic testing is we were suspecting oxalosis as there was significant past history, family history, nephrocalcinosis. So in primary hyperoxaluria, that is the genetic condition, we were suspecting the liver defect continues to produce oxalate. So, and that is not cleared enough by dialysis. And eventually, even on dialysis, that oxalosis progresses with involvement of the bones, heart, retina, and skin, as we shall see in following slides. So that diagnosis definitely affects long-term management, even if the kidneys are not functioning and the patient is dialysis dependent. And it has a very significant bearing on guiding transplant prospects as the patient is young, 18-year-old male, donor is available, mother is available as a donor. And it also allows us to have family screening, although the patient already had a twin sibling death. So that should have been done earlier. In this patient, dietary modification will only help you to a limited extent because once kidney dysfunction sets in, the main source of oxalate is no longer the diet, it is the endogenous production by the liver. So that has to be the therapeutic target. But common foods, the guidelines still recommend to limit intake of oxalate-rich foods. Particularly, they mention about spinach, rhubarb, and particularly common in South India is star fruit, which have very high oxalate contents, and adequate calcium should be provided in the diet. A brief approach to nephrocalcinosis, it can be cortical or medullary, and there were interesting mnemonics to summarize both. So, cortical necrosis, oxalosis, Alport, and chronic glomerulonephritis are causes for cortical nephrocalcinosis, whereas medullary nephrocalcinosis is much more common. and it can be remembered by the mnemonic ham hop. For the medullary nephrocalcinosis, we will have hyperparathyroidism, acidosis, and medullary sponge kidney. Whereas for the pyramids, we have HOP, that is hypercalcemia, oxalosis, and papillary necrosis. So in this patient, we suspected genetic disorder in the form of family history, having medullary nephrocalcinosis, young CKD, and past history and evaluation with an outside 24-hour urine oxalate level of 112, which was done in Madras Medical College. So we had suspected at presentation itself, primary hyperoxaluria type 1 is the most common. So we suspected a mutation in AGXT, and indeed we got the whole exome sequencing done. And its interpretation, there was a pathogenic variant that was detected. So as we can see here, the results itself show us that the mutation was in the AGXT gene, and the transcript is given. It's on the second chromosome, and the location is in exon 1, where there's a duplication at the 33rd position, which causes a frame shift mutation, resulting in an early stop codon that is expressed here, having a homozygous, which is required since the condition is autosomal recessive, and resulting in primary hyperoxaluria type 1, that is a type of hyperoxaluria in our patient, strongly pathogenic. So that was the interpretation of the genetic test in this case. So now talking about a little bit about primary hyperoxaluria, its manifestations and its approach, also known as oxalosis or glycolic aciduria, as we shall see. And it results from overproduction of primarily, as we talked about, endogenous oxalate, and it leads to recurrent kidney stones, nephrocalcinosis, and eventually patients go into kidney failure. So, and after that, even the subsequent storage of oxalate can cause life-threatening disease, as we should see. There are three types: type 1, type 2, and type 3. Type 1 is related to a defect on chromosome number 2, which is aminotransferase. AGXT is the name of the gene and the protein. Type 2 is due to GRHPR, that is a hydroxypyruvate reductase gene, as we shall see in the pathway. And type 3 is due to a mitochondrial gene on chromosome number 10, which is known as DHDPSL. So, most common and the worst prognosis is conferred by type 1, whereas type 2 and type 3 are relatively minor variants, but nevertheless, and their treatment also is not well known in literature and is an area of research. So let's talk about the biochemical pathways in primary hyperoxaluria. So as we shall see in primary hyperoxaluria type 1, we talked about the defect in the liver. So as we can see, there are three compartments that we have: the mitochondrion, the cytosol, and the peroxisome. So mainly in primary hyperoxaluria type 1, we are focused on the peroxisome, where this AGT, this aminotransferase is not available, and the conversion of glyoxylate to hydroxypyruvate is not possible. uh, the glyoxylate conversion to glycine and the hydroxypyruvate conversion to serine, which are utilized in the same aminotransferase, that is hampered, causing accumulation of glyoxylate. Now, this glyoxylate is in equilibrium with the cytosol, and in the cytosol, we have the presence of LDH, and this LDH causes conversion of glyoxylate to oxalate. So, since this aminotransferase is less, we are not able to convert glyoxylate to glycine. The glyoxylate accumulates, and the levels are also increased correspondingly in the cytosol, and the LDH converts it to oxalate, which is further coming into the plasma and getting deposited in the body. Next, we shall discuss primary hyperoxaluria type 2, where the defect is in a cytosolic enzyme, the reductase. This reductase is responsible for the conversion of glyoxylate to glycolate in the cytosol, which is, if when it becomes hampered, the amount of glyoxylate in the cytosol again increases, leading to increased oxalate levels. So this is what happens with regards to increased oxalate in primary hyperoxaluria type 2. Whereas if you look at type 3, in type 3, there is a mitochondrial problem, as we discussed on chromosome number 10. There is an enzyme which gets affected, due to which there is accumulation of a precursor called HOG in the processing of 4-hydroxyproline. These are all precursors of glyoxylates, and this when this HOG accumulates, it is known to indirectly increase glyoxylate levels, and also it indirectly inhibits the GRHPR, which was the target in primary hyperoxaluria type 2, and again indirectly increases the levels of oxalate. So this is an interesting area because we have the development of RNA interference therapy. So as we can see here, so RNA interference therapy, how it is essentially working is that we have these molecules which go and act at the level of RNA, as opposed to gene therapy, which acts at the level of DNA. So the DNA transcript is producing its RNA transcript as usual by transcription, And by the formation of risk complexes, we are targetedly destroying those RNAs so that the protein is not expressed. So it acts upstream than the level of proteins, as opposed to enzyme inhibitors, which would act at the level of the protein. We are acting at upstream targets. And two successful ones are lumosiran and nidoceran, which are successfully used in primary hyperoxaluria type 1. So what lumasiran goes to do is that it prevents the conversion of glycolate to glyoxylate, thereby limiting the glyoxylate production in the peroxisome itself. So it is an inhibitor of glycolate oxidase RNA transcript, that is lumasiran, and the other one being nidoceran. As we saw, the production of oxalate was at all times linked to the use of LDH in the cytosol, LDH isoform A, which is converting it to oxalate. So nidoceran acts at this level of this LDH in the cytosol, preventing its transcript getting converted. So these are the two RNA interference therapies that we have, which are successful in decreasing the levels of oxalate, and we shall discuss their role in further detail. So as we can see, we'll have a look at the systemic manifestations that are there in this, and we'll also go through what were the manifestations in our patients. As we have previously noted, that the moment the patient goes into CKD end-stage renal disease, the hepatic oxalate production, the endogenous production, is the main thing, and it leads to various end organ damages, which are the primary cause for morbidity and mortality in these patients. Uh, Also, the CKD end-stage renal disease, which is of course the core organ manifestation, which occurs earlier. So as we saw, the first head to toe will go. So central and peripheral nervous system, the most common manifestation to that is the peripheral neuropathy. And as we saw, our patient also had a distal peripheral neuropathy. So this manifestation was present in our patient. Other possibilities are autonomic and vascular. By extension, it also affects the eyes, and there is crystalline retinopathy. Some patients will have fundus with oxalate crystals. Our patient, we have a fundus photograph, but it was absolutely normal. There was no oxalate deposition as of now. So further, that can lead to neuropathy, neovascularization, and progressive visual impairment. Then we go to the musculoskeletal system, where there can be striatal muscle involvement. Our patient didn't have any myopathy features or any raised CK levels. We screened this with CK levels. And in the skeletal system, there is documented calcium oxalate deposition in the bone. In fact, for some patients who underwent a bone marrow for the evaluation of anemia in some patients, we have seen beautiful crystals in the bone marrow biopsy of these patients. However, for our patient, we did not do a bone marrow. And another contributing factor to anemia in these patients is CKD. So both the deposition of oxalate in the bone marrow and the chronic kidney disease, both here contribute to the anemia in such patients. So that is regarding the bone marrow involvement, which happens in these patients. The next organ manifestation is the cardiovascular system. And this, in our patient, we screen with a Holter, a 2D echo, and a cardiac MRI is planned. So the Holter was normal, and one of the depositions where a site for deposition of oxalate is the myocardium along with the cardiac conduction system. So patients are known to have heart blocks. Along with that, vascular deposition is also well characterized. So that is a cause for hypertension in our patients. Our patient had hypertension as a manifestation, and that can also be related to the chronic kidney disease that has set in the patient. Apart from that, the 2D echo initially was normal, but post arrest there was some decrease in cardiac function. His ejection fraction currently is 40%. So that is another thing that is there as a manifestation, and we are yet to further evaluate with the MRI. Speckle echocardiography is a technique that is recommended for screening the cardiovascular system for manifestations. Other manifestation is in the that is the core organ, that is oxalate nephropathy, and which leads to progressive CKD, as has already happened in our patient, despite dialysis, persistent uremia elevation, and nephrocalcinosis, which we can see in our patient. Another concern here is the draft related to oxalopathy. So, patients who undergo kidney transplant, it is known and described that the bone marrow is a site where oxalate gets deposited. And even months to years after transplant, it releases that oxalate into systemic circulation, and the liver continues to produce oxalate. So, in patients who undergo isolated kidney transplantation, the graft itself gets affected by oxalate. So, graft oxalate nephropathy occurs, leading to failure of the transplanted kidney, which is a very important transplant planning prospect in these patients. As far as the peripheral circulation is considered, there can be oxalate deposition in the peripheral areas, which can lead to Raynaud's, acrocyanosis, and other manifestations like distal ischemia and gangrene. So, coming to the approach to such patients, we shall first discuss kidney. So what is seen is that the kidney stones, this is an image from the New England Journal of Medicine, where these A, B, and C represent stones from patients with primary hyperoxaluria, whereas the D, E, and F are the usual calcium oxalate stones that are found. So they found a difference that because the rate of formation here is very high, the stones have a different morphology. They are white, pale instead of the usual brown. The usual ones have a slow formation, so they have a beautiful radiating inner structure, whereas the ones in primary hyperoxaluria are usually more disorganized. And more than so these are called as web-like crystals. So more than 200 of these in the urinary sediment is highly suggestive of pH 1. So that would have likely been possible in the pediatric presentation of our patient. And after transplantation, it is in fact a monitoring parameter where less than 100 are required, and you need to achieve adequate hydration post transplant, and the recommended in adult is around 2.5 to 4 liters. And for children, there's a body surface age based hydration that has to be given for such patients. That is the most important. So key cornerstones are hydration, citrate, and vitamin B6, as we shall discuss in coming slides. The next is urine oxalate. So before we go into the cutoffs and what levels we had for our patients, some important pitfalls are: one, the sample has to be an acidified sample, and we need to have a pH of less than 2. Otherwise, there is de novo spontaneous oxalogenesis that happens in samples which have a pH of 8 or more. Accepted normal values are 0.46, and values above 1 millimole per 1.73 meters square body surface area per day is strongly suggestive of primary hyperoxaluria. False positives are seen in total parenteral nutrition, gelatin-rich diet, oxalate-rich foods, and secondary hyperoxaluria. And in fact, the biological variability, that is the day-to-day variability coefficient, comes out to be around 0.32. So at least 33% decrease is required across two samples for a response in treatment. So like urine active sediments, this is also used to assess response to treatments, including vitamin B6 and RNA interference, as we should discuss. Plasma oxalate is very sparsely available. In fact, in India, it is very difficult to get plasma oxalate level. Initially, samples used to be sent to the United States. Now, one or two laboratories are doing it. And they are only used for diagnosis in patients who have already gone to kidney failure and do not have prior urine oxalate levels. And these levels increase with decreasing GFR regardless of etiology. So even on our diabetic kidney disease patients will have increased plasma oxalate levels. So their interpretation should always be compared to a patient with CKD without hyperoxaluria. So patients on dialysis can have up to levels of 50, irrespective of etiology. So more than 50 is the only place where it helps us diagnose primary hyperoxaluria. And during dialysis, the levels can decrease by half. So the timing is important, and they should be compared with values from dialysis individuals without hyperoxaluria rather than normal healthy individuals. Another concept here is paradoxal responsiveness. As we saw here, the enzyme involved is AGT, which is a transaminase, aminotransferase, correct? And all aminotransferases have vitamin B6 as a cofactor. So what they have found is there are certain variants of primary hyperoxaluria type 1 alone, not in type 2 and type 3, uh, as are given the GLY 170 ARG, so and so mutations are there, which are paradoxin responsive. So this is given empirically for all patients of primary hyperoxaluria and documented more than 30% decrease in urinary oxalate excretion after at least 3 months of treatment with the optimal dose is said to be paradoxin responsive. And the doses used here are recommended doses 5 mg per kg. Some authors have used even higher doses, 20 mg per kg, but they're associated with significant paradoxin toxicity. So, and higher doses are only used in select patients. And after we achieve a response with 5 mg per kg, we try to bring down the dose to the least possible dose of paradoxin using the same criteria of paradoxin responsiveness. So as we have seen, the in what are the patients in which we should suspect primary hyperoxaluria? So the key underlying funda is that any age patient with recurrent calcium oxalate stones, as was seen in our patient, or nephrocalcinosis. So any age, if there is recurrent calcium oxalate stones or there is nephrocalcinosis, and it is associated with chronic kidney disease, or either having chronic kidney disease in the proband itself, or there is a family history of kidney stones and chronic kidney disease as was present in our patient, you should use urine oxalate and plasma oxalate. One key fundamental that we have discussed is urine oxalate is very useful when CKD has not set in and is an initial screening tool. Whereas in patients who have already gone into chronic kidney disease where the urine concentration of oxalate is no longer reliable, we have to go by plasma oxalate levels. We do not do plasma oxalate levels for patients who have preserved kidney function. So the normal levels 0.46 millimole for urine oxalate, and plasma oxalate you can have around 50 to 60 micromole per liter on patients on dialysis. As we talked about, regardless of etiology, this will increase. Diagnostic cutoffs are around more than 1 millimole per body surface area, that corresponds to around 88 mg per body surface area, is considered to be diagnostic for urine oxalate. And more than 50 micromole per liter, that is more than 4.4 mg per liter, is diagnostic for plasma oxalate. So our patient underwent these values outside. We do not have detailed reports. We only have the records from the previous records. And our patient's body surface area is 1.6. So urine oxalate per body surface area would in fact even be higher. In 2010, our patient had a urine oxalate of 112 mg per day. And in 2014, it was 84 mg per day, which is well above the cutoff of 88 in the initial presentation. And later on, as you can see, the renal function would have declined. Corresponding creatinine levels are not clearly available, but it was still on the elevated side. And plasma oxalate, we saw it is well above 4.4. In our patient in 2014, it was 9.4. Again, corresponding creatinine is not available very clearly at that point of time. So the management is given in the form of guidelines, in form of a consensus statement by the EarthNet and Oxal Europe associations, which are looking into primary hyperoxaluria. So as we discussed, if the patient has a decreased GFR less than 30, then plasma oxalate assessment is advisable. And what you get is hyperoxalemia, and then we have a genetic assessment is required. We have to exclude secondary causes. Vitamin B6 is started, and we do intensified dialysis because we want to decrease the plasma oxalate levels, and we consider starting RNA interference therapy. If a diagnosis of primary hyperoxaluria type 1 is obtained and the mutation is responsive to vitamin B6, then we continue with, if it is non-responsive, then RNA interference therapy is definitely indicated. If it is responsive, then we consider RNA interference therapy based on the plasma oxalate levels. Further, renal transplant prospects. In these patients, we can consider isolated kidney transplantation based on the response to RNA interference and vitamin B6. Otherwise, we have to go for combined kidney and liver transplantation. We'll discuss this more with regards to our patient also. In young patients, pediatric patients, where we see them in less than 18 years of age and the GFR is preserved beyond 30, or even adults where the GFR is preserved beyond 30, we have to do urine oxalate measurements. Single measurement is not reliable. Two urine oxalate assessments are required. And if it is normal, then it's very good to rule out. We do not have exact sensitivity and specificity, as we do not have substantial cohort data for the same. But normal urine oxalate levels are good, are considered to have a good negative predictive value. Whereas if hyperoxaluria is present, genetic assessment is advised after excluding enteric causes such as IBD, chronic pancreatitis, all the causes of fat malabsorption, which will cause a rise in the urine oxalate levels. And again, we start on B6 citrate and hyperhydration, as we have discussed. In if it is pH2 or pH3, it is not a transferase defect. So vitamin B6 is stopped and there is no indication for RNA interference therapy. So therapies for pH2 and pH3 are still under investigation. Whereas if it is pH1, then we look at response for VB6. If it is responsive, then we continue it. And RNA interference is only considered if urine oxalate is not normalized. If it is non-responsive, then RNA interference therapy is definitely indicated. Now we talk about the RNA interference therapies that are used. I think briefly about the RNA interference therapies that are used. So one being lumasiran, as we have discussed, the other being nedosiran. So lumasiran was acting at the level of glycolate oxidase, and the Illuminate A, Illuminate B, and Illuminate C trials have shown its efficacy. And nedosiran is an inhibitor of LDHA. The key point is lumasiran is used in patients who have deranged kidney function, whereas nedosiran is only used in patients before it progresses to end-stage renal disease. So in our patient, lumasiran is the RNA interference therapy which can be used. Another another one that is not an RNA interference is tiripentol, which is used in Dravet syndrome. And it has been noted that in such patients, the urine oxalate levels were lower than the normal population, because this enzyme is again a direct inhibitor of LDHA. So mechanism of action being similar to nedosiran, only it is acting downstream at the level of the enzyme. And trials for this particular molecule for primary hyperoxaluria are underway. Needless to say, lumasiran is a orphan drug. It does not have any use beyond primary hyperoxaluria. That's why it is very costly. Then we have a further small discussion on the monitoring that is required for such patients. As we already discussed, we are screening for fundus. We are looking into neuropathy with nerve conduction studies. We are looking into the cardiac status using speckle tracking echo, and further it can be evaluated by an MRI. Then we are looking at the bone marrow involvement. We can do a bone marrow if it has been done for anemia evaluation. And then for some patients, we go ahead with the Holter monitoring also. to look for cardiac conduction abnormalities. So these are the various screening tools, especially in children. Growth is a concern, and the height, weight, charts, velocity, because early CKD growth is something that we need to monitor. So currently, the patient was readmitted again for a CRBSI with Burkholderia cynospacia that was treated successfully with antibiotics. And after that, nephrology had taken over because we wanted to plan hemodiafiltration for the patient, in which we use, along with the normal diffusion that is there in dialysis, convection is also added, which allows to remove middle molecules such as oxalate, thereby reducing the oxalate burden. So the patient is currently undergoing daily hemodiafiltration in the dialysis unit in our nephrology ward, and AV fistula has been done for the patient under us. And within the next week, the patient is planned for definitive management for the kidney stone that is present. That is, on the left side, we'll be doing a PCNL, and on the right side, we'll be doing a URSL. And we're already in talks with Lumasirin. So there is the Lumasirin company is running a trial in which they're providing the drug and investigating isolated kidney transplantation. So as we talked before this, the management standard before RNA interference was into the picture, the management standard was liver plus kidney transplantation. In fact, our pediatrics has one patient for which they did the same. But liver transplantation is considered to be a very morbid surgery, and post liver transplantation, the outcomes of the surgery itself, there is significant morbidity. So, what we are investigating is in our patient whether we can do an isolated kidney transplantation under lifelong cover of Lumasirin. So, patient will need lifelong Lumasirin, which is obviously not affordable. But the company for Lumasirin is running a trial in which they are willing, in certain conditions, they are willing to provide lifelong Lumasirin. So, we are in touch with the company for the same. And we plan to do isolated kidney transplantation under Lumasirin cover for this patient. Otherwise, conventional approach, if the patient is considered non-responsive to Lumasirin, conventional approach is kidney and liver transplantation, which is a genetic bearing of this disease. So these are the hemodialysis versus hemodiafiltration orders. So as we can see, in this, there is another flow metric for the convection fluid that is used. And this is a different high flux dialysis. So we can read about hemodiafiltration versus hemodialysis. So that is all. That is all regarding this case. Thank you so much.